First, I want to thank the Socially Responsible Surgery Group, who's this is an organization that has now been here, I think, 4 years, and we are really coming into our own in terms of putting this together. We're the second chapter of Socially Responsible Surgery in the United States, and proud to have been a part of this really forward-thinking and, I promise, the future of surgery organization. So as you have noticed, part of the summer has been to really highlight the work that's being done in this space and the importance of it to our surgical patients. So today I'm really thrilled to present Dr. Elise Hill, who is actually leading the research arm of this group, but also is one of our star research residents right now. If you don't know, she is a graduate of the United States Air Force Academy. And if that were not enough, she, while there, received, it's called the Dean's Aces List, which is people who got a 4.0 during their time at the Academy. I just want you to take a minute to be incredibly impressed, because you should be. She now is, so she went on to get her MD at the University of Iowa, came here for her residency at UC Davis, and is now working on her Master's in Public Policy and International Affairs at Princeton. She has a long history of accomplishments and awards related to this, as one of the people that we were so interested in to sort of develop and enhance our public policy footprint, being in the Capitol and having lots of opportunities to impact those incredibly important things that influence healthcare now, perhaps even more than the day-to-day things we do on patients at a time, but the unbelievable challenge that exists in our healthcare system. So with that, I'm going to turn it over to Dr. Hill, and really excited to have you this morning.
Okay. All right, so hello everybody. Thank you so much, Dr. Farmer, for those kind words of introduction, and also for just allowing the space for this Socially Responsible Surgery Grand Rounds. So today I'm going to talk for about 40 minutes or so, and there'll be some time for Q&A afterwards. And I'll talk on the use of race in medicine, and in doing so, talk about the intersection of genetics and the political determinants of health. And I'll kind of get into what I mean by the political determinants of health later in the talk. So I have no disclosures or financial conflicts of interest. Also, the views in this presentation represent my own and not the views of the U.S. Air Force. So a quick agenda. I'll touch briefly on my research interests, kind of the space I hope to occupy after leaving. And then I'll get into kicking off the concept of race, how we consider this in relation to ancestry, and importantly, why having a thorough understanding of what race is and what it isn't is so vital when considering its place in medicine. I'll then discuss some historical and contemporary uses of race in medicine, from diagnosis to treatment and representation in research. I'll then touch on health disparities, really setting the stage as to why race is such a huge topic in medicine, and why the nuanced consideration of this term is necessary as we move towards health equity in this country and the world. I'll then present some data from a personal project which looks at racial representation within COVID-19 clinical trials. I'll then switch gears to defining the context and setting the stage to considering the issue of race in medicine through two different lenses. Firstly, I'll touch on the social determinants of health, and again introduce a lesser discussed concept of the political determinants of health. I'll present some data from another project that I've done on the Federal Highway Act and contemporary asthma healthcare disparities and how those two things are related. The argument here being that although race has no biologic basis, which I'll get into, race certainly is very important in how we view health and healthcare through a shared social experience, especially in America. The second important lens to approach this topic with is an understanding of how modern genetics influences our understanding of race, and how we can use this knowledge to weigh the use of race in medicine. In this part of the talk, I'll talk about the troubled past of genetics, particularly in America, and the future promise of precision medicine. Here I'll touch on epigenetics and how this concept really connects the political and social impacts to a biologic result. I'll wrap up with my takeaways from all this information, what I hope that you guys can take away from all this information as providers and also possible advocacy and future policymakers. And we'll talk about when should race be a factor in healthcare and health policy. So just to get started, so my research interests are basically in how policy, broad public policy, not just health policy, impacts health. How political determinants of health through epigenetic changes in our DNA lead to epigenetic factors and surgical outcome disparities. So to begin, and through this talk, I'm going to ask for a little bit of audience participation, so hopefully a couple people are comfortable speaking up. I want to talk about how race is a social construct, and to talk about that, does anyone have a definition for race? Like a factual, what is race definition? No? I think that that's pretty accurate, that no one can accurately define kind of factually what race is. And I'd like to go ahead and demonstrate through two examples that race is a social construct. And what do I mean first by what is a social construct? So when I define race as a social construct, I mean that the modern conception of race doesn't actually exist in objective reality. Nobody can actually really define exactly what it is. And this has actually arisen as a result of human interaction, an idea that's both created and maintained by members of a society. So I'm going to start here by the definition of race as given by Merriam-Webster. First, I'd like to point out that there's a current, a dated, and an archaic definition of race. And this just demonstrates the changing definition through time based on societal, kind of where we are in society. Currently, it's defined any one of the groups that humans are often divided into based on physical traits that are regarded as common among people of shared ancestry. So seeing these words often, regarded, really not being able to nail down what exactly races are. Also, I really like this quote here from Britannica that basically states that at no point from the first rudimentary attempts at classifying human populations in the 17th and 18th century to present day have scientists agreed on the number of races of humankind, the features to be used in the identification of races, or the meaning of race itself. So we kind of start to see the problem, right? We're using something that's very, very subjective in a pretty objective practice of medicine. Another interesting case study is specifically the use of race in America. And here I've just zoomed in on the census race categories to kind of illustrate this changing race definition. Zoomed in on the people of Asian descent and people of African descent categories because I think it's the most interesting. So back in 1870, we can see that of Asian descent, where basically the only option was Chinese, where obviously there's many different categories of Asian descent. And then black and mulatto for the African descent category, mulatto meaning mixed race. As we move to 1890, we see the addition of Japanese, but also the addition of quadroon and octoroon in the African descent category. Now this has arisen because of what's called the one drop rule, which basically is saying that if you have one drop of African blood in you, you are black in this country. And there was really a focus on that in society at this time, so that's why you're seeing that change in the racial category there. As we move to 1930, we see an expansion of the Asian category. You know, people were really concerned in this country in defining what type of Asian you were. And that's why they really tried to nail down, are you Chinese? In particular, are you Japanese? And we're just kind of seeing society reflected in this definition of race. And then we see the appearance of the word Negro. And then as recently as 2010, again, we see a lot of different categories for Asian ancestry, and then Black, African American appears, and Negro persists. So I think two things are interesting for this case study. Number one being the persistence of the word Negro in 2010. I was surprised by this, and people are probably surprised by this. And so I think, again, it all goes back to race being a social construct. It's created and accepted by members of a society, including the populations that aren't in power and have never been in power. Power being defined as the class that defines a reality for society. So because individuals of African descent lived through a time in which their identity was so defined by their oppressor, some to this day are unable to recognize their identity by any other way. And so they were finding that some African Americans were marking nothing if they didn't put Negro on there because they couldn't define themselves in any other way. Also, I think what's interesting is kind of the expansion of the Asian descent category, but Black is always kind of Black. There's no expansion, there's no ancestry here, right? It's just an identity that again, is defined by those that make definitions for our society. I just wanted to point out the unique case of being Black in America and why being Black in particular is such a problem in medicine, because there's so many different ancestries, Afro-Caribbean, African, even Blacks that come from Europe, but we're defining them all under this umbrella of Black. And I'm just going to say that hopefully through the advent of genomic sequencing, this population can get a better idea of their ancestry should they so choose. Okay. So I'm going to move forward and provide some examples of the historical and contemporary uses of race in the practice of medicine, anywhere from diagnosis to treatment. On this slide, I'm just providing 2 examples of the use of race in the diagnosis of disease. And I chose these 2 examples because they actually provide contrasting results. So firstly, this is the formula for the American Society of Cardiovascular Diseases heart disease risk calculator, which we do use sometimes when evaluating a patient for surgical risk. So we can see here that there's 2 categories, one for African American and one for everybody else. This actually overestimates the risk for some Black patients, and it can result in overtreatment with things like statins and other medications that have side effects when you might not need to be treating it. And this model actually also acknowledges that it underestimates risks for American Indians, South Asians, and Puerto Ricans, and overestimates risk for, like I said, African Americans, East Asians, and Mexican Americans. So what's the problem here? We're overestimating, we're underestimating, we're not very accurate, right? So the problem here is that they're using race as a proxy, basically, for a biologic difference, when in fact the variance in risk is likely due to social factors affecting the averages among populations. But, there's a concern here that we're overtreating and undertreating. And then the second box shows the opposite thing for Black patients. The formula calculates GFR, diagnosing kidney disease as we know. African American race is used as a modifier in this case due to a presumed higher muscle mass of Black patients. And as we know, there are very muscular white people and not very muscular Black people, so this is obviously an issue and actually leads to later diagnosis of kidney disease in Black patients that can delay dialysis, delay transplant for these patients that are already at a higher risk due to societal factors. Let's see if this works. Yeah, quick video here.
My name is Renelle.
About 3 minutes.
I'm 48 years old, a nurse at a healthcare facility. I got 5 kids, a full schedule, and heart failure. I had noticed I had shortness of breath after walking just a short distance. Then one day I woke up, I had trouble breathing, and said, there is something seriously wrong here. I shouldn't be feeling like this. So I went to the hospital. My blood pressure was extremely high. I had fluid in my lungs. They told me I had congestive heart failure. They even thought I might need a pacemaker.
Renelle came to my heart failure clinic after being hospitalized for heart failure. When I first met Renelle, she was so overwhelmed and exhausted. When she told me her story, I could see why.
Here I was with 5 kids, high blood pressure, and now I have heart failure. I was overwhelmed. Sandy calmed me down and explained to me my diagnosis, what treatment was available to me, and gave me advice on how to take care of myself.
The first thing Renelle and I did was to sit down together and make a plan. It's important to find out what's important to a patient and how we can create a treatment plan that covers lifestyle changes and medications. We talked about life goals. What do you want to do? How are you feeling about things?
I had been diagnosed with high blood pressure about 14 years ago. I was very non-compliant with my medication. Now, after heart failure diagnosis, I know I need to take my medication every single day.
One of the medications I recommend to my appropriate patients is Bidal. Bidal is indicated specifically for African Americans with heart failure. It's used with standard heart failure treatments. Renelle is like a lot of my heart failure clinic patients. They're often resistant to taking medications, but I find once I talk to them about Bidal, about what they can expect and how it may benefit them, they're open to it. Renelle and I talked about the African American Heart Failure Trial, also called AHEFT. The study was the first heart failure study to include self-identified African Americans with heart failure. I showed her all the benefits of Bidal that were seen in the AHEFT trial when Bidal was added to standard therapy. A 43% improvement in survival, a 39% reduction in the risk of first hospitalization for heart failure. Bidal also demonstrated an improvement in functional status. Of course, Bidal isn't right for everyone. Patients who shouldn't take Bidal include those who are allergic to organic nitrates or who take a phosphodiesterase type 5 inhibitor, as taking the two together may cause severe hypotension, syncope, and myocardial ischemia.
When Sandy first talked to me about Vital, I thought, well, okay, this is something studied in patients like me. I took her.
All right, I'm going to stop it there. I just think that this is a really interesting ad for a medication that's only approved for African Americans. It does a lot of blurring between biology and social experience here. It talks about medication noncompliance. It talks about being resistant to taking medication. It uses rhetoric like people like me, and it really just blurs that line. And again, we might be giving people medication that they don't necessarily need or withholding them from white patients that might benefit from this medication, and we're just basing this on population averages. Okay. So since we've been theorizing about the dangers of using race as a biologic proxy, I'd like to present a really interesting study from 1997 by Richard Cooper. First, I want to give this quote here that's on WebMD, which a lot of our patients look to for their medical advice. Being Black is a risk factor for developing hypertension. So that's just there for our patients to see, right, and digest and basically take on as their identity. But here, Cooper looks at 6 different West African populations and their prevalence of hypertension, so Black populations. And so we see here that the prevalence is ranging anywhere from 15 to 30%. Interestingly, that's much lower than the prevalence of hypertension in non-Hispanic Blacks in America, which is 54%. And further, much lower than the prevalence in non-Hispanic whites in this country at 46%. So I'd like to kind of amend this. We're putting out there that being Black is a risk factor for hypertension, but really being American is a risk factor for hypertension. And in particular, being Black in America is the risk factor for hypertension. And this really is an argument for social determinants of health instead of a biologic assumption of race. Okay. So now that I've defined race, kind of discussed its use in medicine, started to deconstruct its use in medicine, hopefully for you, I'm just going to touch really quick on something we all know. Why do we care? We care because there's all these health disparities that persist even when controlling for socioeconomic factors, exist at all levels of healthcare experience in this country, including access, outcomes, and participation in research. Here's just one thing I could choose out of many for access. Uninsurance rates ranging from, we see 7.8% in the white population to 11.5% in African Americans, up to 20% in Hispanics. And also I'd like to point out here, I talked about how on the census categories, the Asian category had really expanded to encompass a lot of different ancestral categories, and I'd just like to point out the problematic nature of lumping all Asians into one category for research, because, they have very different social experiences that affect their health and access to care. Here's just some selected health disparities. We all know this. Black, Hispanic patients have worse outcomes and higher chronic disease rates. And then to bring it to surgery, these are some surgical disparities post-operatively in Black versus non-Hispanic whites in this country. So these are odds ratios. All-cause morbidity is 1.1, all-cause mortality is 1.15, readmission rates 1.12, and then DC to rehab versus DC home 1.73. And then in terms of these disparities collectively lead to a life expectancy of 6 years less for Black Americans in this country as compared to white Americans, which is huge. It's huge when we consider the leaps we've made in life expectancy over the last 50 years. And then maybe even worse is racial representation in scientific research. So as we can see here, the different categories representation in the general populations in green, followed by oncologic clinical trials and genomic databases. Asians are pretty well represented, but again, the issue there, they're not all the same. But Blacks and Hispanics, as we can see, are really abysmally represented in scientific research. So here I'd like to present a contemporary example. So I asked, what are the demographic reporting and representation characteristics in COVID-19 therapeutic clinical trials? Just a reminder here that Blacks and Hispanics had higher rates of infection, hospitalization, and death, even though they had lower proportions of the population. So we knew that. So these are the initial vaccine trial diversity data. So again, here in green, percent US population, and then in pink is percent representation in Moderna trial, and blue is in the Pfizer trial. So we're seeing here that the initial enrollments in the trials was actually pretty promising. Especially down here for Blacks, they're at about 10% representation, and they represent about 13% of the population. So while not quite parity, that's so much better than what we've seen in the past, and Hispanics are very well represented. So what I did then, though, was I looked at all clinical trials to date. So not just initial enrollment, but follow-up trials, safety trials, other therapeutic trials. I split them up into vaccine-related and non-vaccine-related. And as we can see, when we're looking at actual vaccine follow-up trials, looking at safety, looking at efficacy, we have a drop-off here in representation. So Black representation going from about 14% or so in non-vaccine-related trials to about 5% in vaccine-related trials. And when I did a qualitative assessment of what are these non-vaccine related trials, many of them were non-pharmacologic interventions, so phone interview things, mental health things, things like that. Okay. So I just want to pivot now to the two frameworks I discussed in the beginning that we can consider race and medicine through, from a socio-political lens and then a genetic one. So to begin, does anyone know what social determinants of health are? I know that you guys know this one. Anybody? Yes.
It's basically non-medical things that can affect your health, like your environment, your social circles, your economic status.
Great. Yeah, perfect. Thank you. And then just
for the microphone.
yeah, so she said non-medical things that affect your health status. So kind of, access to care, nutritious foods, schools, things like that. And here I just basically have the definition that you just say. It's from the Department of Health and Human Services, that these social determinants of health are the conditions and the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, quality of life outcomes, and risks. And here are just some examples that you kind of provided some as well. So things like lack of access to nutritious foods, polluted air quality, poorly resourced schools, neighborhood violence, and lack of safe and affordable housing. So here I kind of want to pivot and reframe, because I think the language that we use to describe things is really important. I think it's important that we recognize that these things don't develop in a vacuum, and they're actually the result of very deliberate policy over the course of centuries and decades here in this country in particular. So I can point to policies that cause these things, right? So things like segregation, things like separate but equal rulings in the Supreme Court, redlining, suburbanization, gentrification, air quality regulations that are different depending on what community you're looking at, zoning laws, kind of how they administered the VA loan program, who they gave home loans to, and like I'll touch on the Federal Highway Act. Now because of this, I call these things the political determinants of health rather than the social determinants of health, because we need to recognize that we can do things to change this. So here's just an example. I did this project last year. I looked at the contemporary effects of the 1956 Federal Highway Act on asthma-related healthcare disparities. My impetus for this study was kind of looking at three truths. The fact that asthma is one of the worst healthcare disparities in this country, both for prevalence and severity in particular. So prevalence is about 11% versus 7.8% when comparing non-Hispanic blacks to non-Hispanic whites. But what's really, really shocking is the severity. So as we can see here, black males when compared to white males have a 6 times higher death rate from asthma, which is just terrible. And then also asthma is particularly well suited to kind of epigenetic study, social determinants of health study, because it's a respiratory condition that's very influenced by environmental factors. And there's also a pretty well-established epigenetic inheritance to asthma. And then also there's a very well-known policy that you can kind of point to as maybe causing some of these disparities in the Federal Highway Act of 1956, which basically, under the guise of kind of urban renewal, they built these huge highways through predominantly black communities and displaced these communities, and we still see the effects of that to this day. So as a case-based study, I asked, in neighborhoods where highways were historically utilized as instruments of urban renewal, is there an increased contemporary risk of asthma based on highway proximity? I did 6 different cases. I'll present 2 today quickly. My methods were such, so Rondo basically is where you see the ones, that's basically where the neighborhood of Rondo in Minnesota was. And my methodology was a census tract level analysis. What I did was I labeled the census tracts that intersected the highway, in this case I-94, as 1 census tract removed as group 2, and 2 census tracts removed as group 3. I then looked at prevalence of asthma contemporarily and percent African American populations. I also tried to do kind of a little bit of a qualitative component to this, And this is how residents described Rondo prior to this highway construction. So love flowed in the streets. A sense of community is not a strong or emotional enough term to describe what we felt, and everyone was your relative. After this, the community was completely displaced. Businesses were destroyed. And here are my results from the study. As you can see, the prevalence of asthma today along the highway in group 1 is about 11.4 as compared to about 9.3 in groups 2 and 3. And you can just see it kind of mirrored in terms of where we're looking percentage African American residents. This is just another visualization. You can see percentage Black or Latino as dark blue, and then the bigger circles represent higher prevalence of asthma. And then TREM was interesting. So in Louisiana, New Orleans, this was an interesting case study because originally the government had planned to build it along the French Quarter, which is a predominantly white community. But then local and national actors came out in defense of the French Quarter, successfully defeating this proposal, and therefore it was built through the predominantly Black community of TREM. And so this just demonstrates lack of political voice in minority communities and what that can mean for your social and political determinants of health. And again, it just also mirrors kind of what I found in all of the other case studies, that the prevalence is much higher when you're closer to a highway. Overall, I found a significant difference. These are all 6 put together with a prevalence of about 12.5 versus about 10.5 for asthma. So my conclusions and takeaways from this, it's not necessarily causation, but there's definitely correlation here. There's asthma health disparities, there was this destructive highway construction, and we know already through established research that highways increase asthma risk. We know that these epigenetic factors are present and that, we can cause multi-generational disparities from this. And as distances to highways decrease, asthma rates increase, and the likelihood of being Black increases as well. So what do? We can recognize the real impact of policy on health disparities and match the level of disinvestment with new investment. We need, I would say we as in healthcare advocacy people and obviously policymakers need to recognize how much we did to get here and how much it's going to take to get out. Okay. So I'm going to turn to genetics. We're going to consider the troubled past of genetics in this country, modern genetics, and the precision medicine and the promise there. So I'm going to play also a quick video here talking about the eugenic movement, kind of forced sterilization, just to kind of set the stage as to why it's such a touchy topic in this country. Maybe. Maybe not. Nice.
Today I am here to acknowledge a great wrong that was done to more than 2,600 Oregonians over a period of approximately 60 years. Forced sterilization in accordance with a policy known as eugenics. Between 1900 and 1925, Oregon was one of 33 states that enacted to provide forced sterilization. The Oregon law established a state board of eugenics. The board's job was to decide which people should undergo involuntary sterilization in the interest of promoting a higher quality of human beings. That is a part of Oregon's history.
In 1923, Oregon enacted a eugenics law for the compulsory sterilization, or even castration, of people deemed feeble-minded, insane, epileptic, habitual criminals, moral degenerates, and sexual perverts.
Positive eugenics was the notion of having the best examples of humanity match up and have children that carried on those paragons of virtue. And then the negative eugenics was keeping the misfits and the threats to social order, keeping them from reproducing.
The eugenics law eventually included terms like antisocial behavior or sexual deviancy. So this was a very wide net. The use of eugenics as a so-called therapeutic tool really meant that there were some very horrible things that happened.
Fairview Training Center was the state's institution for those with developmental and intellectual disabilities. For decades, residents were required to be sterilized before they could be released.
Just going to stop there because I think that it gives the idea of what happened. So while the video, I think, did a pretty good job of describing the dark beginnings of genetics, it kind of failed to touch on the racial component of it. They did kind of allude to the fact that this was a pretty wide net, so basically they could use this as a reason to sterilize people, but I want to draw your attention here to the fact that, you know, in the beginning of the century, rates were pretty much the same along racial groups, but then after desegregation and the civil rights movement, we see that rates of sterilization of black women are 6 times that of white women, so obviously this was used as a pretty dark tool in this country. So because of that, many geneticists, social scientists, medical professionals, and others continue to debate the correct approach to race and genetic research, and they try to strike a balance between social responsibility and scientific objectivity. But I think most would agree we need to ask the question, what does modern genetics actually tell us about the biologic basis of race? And how can we use this knowledge to better understand the role of race in medicine? So I'll begin here with some facts, and the fact is what makes us different really pales in comparison to what makes us the same. And humans are 99.9% genetically homogeneous, and among that 0.1% of genetic variability, 85 to 90% of that variability is found within large groups rather than across them. So only 10 to 15% of 0.1% of genetic variability is found across broad population groups that, you know, don't map perfectly, but are kind of our modern conceptions of race: African, European, and Asian descent. A lot of my figures and data over the next few slides are from an excellent article by Jordan Wooding, and I've linked it here if you want to take a look. But here we have a good branching chart, genetic branching chart, and as we can see here in green is those of African descent, and these are people that still live in Africa, very geographically isolated populations. We see here in blue Europeans, and then in red East Asians. So what I'd like to point out here is, for example, the San African population and the Hema African population, both of which would be considered black by our modern conceptions of race, are much farther apart than the Hema population and Northern European population. So when we consider genetic basis of race, we need to keep that in mind. And then from the same study, the authors basically tried to see if they could reliably predict ancestry for geographically isolated populations of African, Asian, and Europeans. They actually used 190 highly variable polymorphisms to do so, and they found they were pretty accurate when characterizing these widely geographically isolated groups. Now keep in mind, this is not in America. This is taking people in Africa, in Europe, in Asia, and trying to do this, and they used 190 genes to do so. So when we look at here, more admixed populations, different migration patterns, we add in South Indians, you can see here the yellow, you know, it's not reliably mapping onto anything. And then here is the American case where we can see African Americans kind of, a lot of them are halfway in between Europe and African in terms of genetic diversity, and that's still with the 190 polymorphisms. So they note, the authors note, that race doesn't necessarily equal ancestry, especially among admixed populations and especially in America. This is a kind of complementary study by Teo et al. And colleagues in 2011. So what they did was take African Americans and Hispanics in New York and genetically sequence them for European and African descent. Here we actually have European descent shown in blue and African descent shown in red. So what we can see here is that a lot of these Black people or Hispanic people have a lot of European ancestry. Some of them have almost all African ancestry, but you're unable to reliably predict where you're going to fall based on a phenotype of race. So what are the implications for medicine here? So often in medicine, we're not talking about 190 polymorphisms, right? We're talking about maybe one gene. So the authors look at one gene here. They look at the AGT gene, which basically gives you a higher risk of hypertension. And as you can see, while using the 190 original ones, we're able to reliably predict. When using the one gene, it's all over the map, right? So again, this gene is present into maybe up to 90% of African heritage populations, but also 30 to 40% of whites. And so if we're making treatment decision based on genetic assumptions, we're missing a lot of people, we're treating a lot of people wrong. Okay, so before I move on to precision medicine, I kind of want to touch on something I kind of struggled with when looking at all of this data. Is there a concern? So I asked myself, okay, knowing all of this, what am I supposed to do? All I have are averages. Am I supposed to not treat somebody with, say, an ACE inhibitor for a Black patient when I know that they're at higher risk? And so I think that the answer is we don't know enough yet to say exactly what we're supposed to do. What I think is important is to recognize what we don't know. And what we don't know is that this patient is this way because of their phenotypic race. And so you can keep averages in mind, you can keep risk in mind, but be open with your patients about, it doesn't necessarily mean you mean it, but you might have a higher risk. Let's try this, but be quick to change if they're not responding in the way that you think. So what's next? What's next for genetics? Can precision medicine replace the use of race in medicine? So the concept here is that individually tailored treatment is not based on group generalizations, but on your specific genetic makeup. It's used a lot right now in oncologic therapies. For example, we take out somebody's breast cancer, we send it for genetic sequencing, we know what chemotherapy they're going to respond best to, and we treat them as such, rather than just treating, say, all Black patients this way, all white patients this way, this, that, and the other, right? So can this be expanded? Can we envision a future where we genetically type everybody and where we treat them based on their own genetic milieu of different variants? And I think so. As what we see here is the cost per human genome, currently estimated about $1,000 per the NIH. So it's getting lower. I mean, it used to be crazy expensive, and look how fast we did this, 20 years. So I'm really excited for the future. I'm really excited. I do think that this will replace race in medicine. So 2 final notes. I've mentioned epigenetics quite a bit in this, but I just wanted to kind of define it. So it's the study of how your behaviors and your environment can change the way your genes work. So unlike genetic changes, these changes are reversible. They don't change your DNA sequence, but they can change how your body reads the sequence and change the phenotypic expression of your genes. There's really interesting research around this. They're attempting to investigate the heritability of these epigenetic modifications. And currently, G1 inheritance is pretty well established. That is, environmental impacts to a mother that's pregnant are going to influence the health of the fetus. G2 inheritance, also well established. That fetus that was exposed in utero to this environmental factor can pass on poorer health to their fetus. But the question is G3 inheritance a thing? Is a fetus that was never even exposed to the environmental insult able to pass those on to their offspring as well? And, it's an exciting area. It can help to explain both persistent outcome disparities, even when controlling for socioeconomic status, can also help to explain the heritability gap, that amount of heritability of traits that we don't understand yet. And then before I kind of wrap up, I wanted to broach a little bit of a personal hypothesis, something I think we need to be on the look at, and that is kind of a circular argument. Particularly in this country, there is a lot of structural racism. There still is, and there certainly was. And that impacted minority communities, particularly Black and brown communities, leading to higher health disparities in those communities. Now that that's already in place, when we're doing these genomic studies, we are finding higher frequency of different variants among groups, because although race doesn't map directly onto ancestry, it does to an extent. You're going to find higher frequency of this allele among those of African descent, and perhaps because of structural racism, you're going to find higher diabetes in that group too, leading to these race-based genetic associations that might be due to a shared social experience rather than an actual biologic risk. Okay, so I want to talk about some practice and policy recommendations based on all of this, try and broach the topic of when should race be a factor in medicine. But first, I want to touch on some positive things. So the medical community overall is acknowledging this and is moving towards a brighter future in terms of these topics. Firstly, the National Kidney Foundation this year came out with a new way to diagnose kidney disease that removes the African American component and rather focuses on a specific protein measurement in each individual. So that's great. And then also JAMA released in 2021 updated guidance on the reporting of race and ethnicity in medical and science journals. And within that guidance, this is this great quote that I think all health policy and kind of decisions we make should emanate from, that race and ethnicity are social constructs with limited utility in understanding medical research, practice, and policy. However, the terms may be useful as a lens through which to study and view racism and disparities, inequities in health, healthcare, and medical practice, education, and research. So again, recognize the limitations, recognize it's not a biologic proxy, but also, particularly here, recognize that there is a shared social experience of races in this country that might impact health. So I kind of tried to do a practice recommendations and policy recommendations for anybody who is into advocacy, maybe future policymakers or current policymakers. So I think medically, medical calculations should be done on an individualized basis, personalized medicine should be encouraged, and practitioners should maintain an awareness of risk while focusing on the individual patient. Policymakers should refrain from basing health policy on race, except when the policy is related to a group's shared social experience rather than a shared biologic assumption. So I want to conclude here, and I want to emphasize that we should all have an interest and can have an impact in providing socially responsible care to our communities. Several of your colleagues have already made huge contributions in this arena, and there's endless ways to make a difference. So in the top left here, Dr. Alexander Borowski in the Department of Pathology has really led the charge for UC Davis's participation in the All of Us campaign, which is aimed at improving genomic diversity. It's huge. And then over here, top right, Dr. Elise Tong of Internal Medicine has really been instrumental in the recent ban on flavored tobacco, which, as we know, flavored tobacco disproportionately impacts community of color. And then our own Dr. Cook and Brown, as we all know, have both carried out really impactful work in both equitable vaccine distribution and the prevention of recidivism for the violently injured trauma patients through his wraparound program. Together we can make a difference, but it takes all of us looking at this profession through a socially responsible lens. And I'd like to thank Drs. Cook and Godoy for their help with this presentation, and I'm happy to take any questions.
Well, I just want to start out by congratulating you, Dr. Hill, on an extraordinarily excellent presentation and bringing such important topics to life in such a professional and accessible way. And I think it really is just a testament to your many outstanding leadership, intellectual, and socially responsible qualities. So let's open up the conversation. Dr. Calcutt. Oh, I got it.
Great talk, and I am especially glad that you began with the idea that race is a social construct. So we've been talking about this for more than 20 years, yet it's taken a long time to diffuse into the medical community. My graduate school training while I was a resident was in health services research, and I had an emphasis on clinical trial design methodology, and one of the things that struck me back then was the lack of inclusion of traditionally underrepresented groups in clinical trials work. And that continues to be a huge problem. And I get up to say two things. One, I'm particularly proud of us here at UC Davis. Dr. Farmer knows this, but we actually went out during the COVID pandemic. You probably don't know this because our research isn't published yet, and got specific funding from the California Institute of Regenerative Medicine to actually offer stem cell therapy to traditionally underrepresented groups in a clinical trial for the treatment of COVID-19. And here locally, all but two of our patients that we enrolled are from groups that traditionally would not be included in research. So there's a misconception in research, which you didn't talk about, which is part of why I got up and hoping you can comment on some of your work in this area. There's a misconception that people from particular groups, including the African American population, are reluctant to participate in research. Thus, that is why one of the justifications for why the numbers are low. That has not been my experience. If we approach them in a culturally competent way, we've had great success in my research back at UCSF and here in enrolling those folks in trials. But that I hear over and over and over again. So I'm hoping you can comment on that. And the second, which is just more informational, is we need an extraordinary amount of work in the policy arena in this realm. And I will just say, every year when I submit my progress report to the NIH for my grants, it just so irks me that I have to report the enrollees based on race. And they have not yet moved in the federal government away from those reporting standards for us. And so wondering if you could comment.
Yeah, thank you so much for your question and your work in this arena. Thank you for that. So the first question, so there's several things I want to say on that. There's actually a great podcast called It's Not Just Tuskegee that SRS actually used as their first kind of roundtable discussion. It talks about how a lot of people reference the Tuskegee syphilis experiment as a reason that Black people don't trust medical care. And it dives into the fact that it's not just Tuskegee, it's about the current treatments, it's about the current experiences that Black and brown communities are having with the medical profession, and we need to recognize that it's ongoing. These microaggressions, these cultural complications, we need to take responsibility for that and be better. Secondly, there's a lot of studies showing, just like Dr. Calcutt said, that when asked, Black people actually participate in research at higher rates, okay? So when you approach them in culturally competent ways, when you provide resources for lower socioeconomic status communities, things like transportation, things like translation services, things like, having sites in their community rather than having them come to your hospital. So all of these things are things that I think need to be incorporated into people's research budgets so that we can actually improve, participation. Because again, it's not that they don't want to, it's that sometimes they can't based on their social circumstances or how they're approached. I actually think that when last year I made a policy recommendation that IRBs shouldn't approve studies that don't show, ways that they're going to try and mediate the issues of enrollment. So I think that maybe is somewhere we could start and maybe lead the charge here at UC Davis with that. The second question, the reporting of race in studies. So that's a hard one. Where we are in this country, the way that we are categorized is by race. And currently we don't really have a better way, an infrastructure that's a better way necessarily, unless we're going to genetically sequence everybody that we enroll in trials, which hopefully, again, we're headed towards. Hopefully we can, base things based on, genetic sequencing rather than a phenotypic appearance. But I think we have to start where we are. And so I do think it's still important to report race because there is this shared social experience that does impact things. And it's important to know that too. But I do hope that while we do that, we move towards a more biologically accurate categorization of people in this country. And I think we're moving towards that. So thank you for your work.
Dr. Brown.
I have to go to a 911. Excellent talk. Just a couple of things. One, did we, like you said, the experience of many of us in America is based on racial identity. And so I don't think that anytime soon you'll be able to take that out of the analysis. But I think that precision medicine will be an adjunct and hopefully a bigger and bigger adjunct as you go forward. That was amazing. I also noticed in your one slide where you had the 6 different categories in hypertension that the highest hypertension was in Maywood. And being from Maywood, Illinois, I just needed to know if that was what you were talking about.
So it's not Maywood, no.
The guy is paranoid.
That is a crazy coincidence, but no.
Oh my gosh. Other comments? Other thoughts?
Are there any Zoom questions or anything? Does anyone see?
Yeah. Dr. Godoy.
Just mainly a comment. That was a fantastic talk. You covered so many different topics that each by themselves can merit their own grand rounds. The future, epigenetics and sequencing and precision medicine is a hot topic right now, and just like you highlighted, it's important for all of us to be thinking about these things when we're trying to enroll and talk to our patients about clinical trials. And like you covered, people, if you present these studies and the importance for future generations, are willing and able to enroll in a lot of our studies. A lot of people, like you mentioned, also chalk up the low rates of enrollment on the quoted mistrust. So people automatically assume like, oh, this person based on their race is going to be mistrustful. So, we're not going to spend that extra time on enrolling the patients. But I think you really highlighted a lot of really important areas that we can all improve. So thank you for that talk.
Thank you.
I want to make just a historical observation to a certain extent. I'm old enough to have remembered in communities, particularly I'm thinking places I lived growing up, Chicago and Boston, where many of if you talked to grandparents in white communities, the issues were the Polish versus the Italians versus the Irish, and that there were enormous issues related to this different ancestry in communities, that it occurred violence and lots of issues. You think of, there's Little Italy in all of those communities, and the historical challenges in Boston with the police and Irish descent and Italians. And I think some of if you just look at I was struck with your timeline. And for example, in California in particular, some of the relative atrocities that were committed among people of Asian descent around the time of immigration and bringing people into work in the railways and et cetera. So there is a repeated history that changes over time in terms of who is the different group. And it's a lot about differences. And we actually do have to remember the only Americans that are real Americans are Native Americans, and that this is a country of immigration, and that we almost all, looking around this room, come from an immigrant background in some way. And so just figuring out how to get human beings comfortable with otherness and differentness is sort of a core historical challenge. We are in a different phase right now for a variety of reasons in history. The politics of how we define these groups influences who is the other group in any different decade. And it's I just was really struck with your timeline when you did that, and just thinking back to the stories that my grandparents told about their sort of immigration history. And it's just really an interesting observation that you made me think about, and just a reflection on the important work you do that's never done in our history of humanity. And you just look around the world, and all of the wars that are happening everywhere are somehow rooted in this lack of willingness to accept differentness. It's really such profound things you've brought to bear. Thank you for your great work. Thank you for your commitment to policy. It was always one of the four things I observed when I came here. What was unique about Sacramento? We had a vet school. We had public policy. We had the capital of the largest state, essentially in the United States, bigger than the country of France, and that there was an extraordinary opportunity here. Thank you for walking through that door so expertly. All right, thanks everybody. Have a great day and a great week.